Good day, everyone. My name is Dr. Alden B. Williams. I'm an interventional pain management specialist. I have a Center of Wellness and Regenerative Medicine, and I specialize in multiple things, which includes intradiscal ozone therapy, which we talked about several years ago when we talked about spinal augmentation and intradiscal ozone therapy on the YouTube video. And that's been a while now. So I'd like to actually talk to you more about where we've advanced from then until now. And one of the things I'd like to make sure that everyone understands that everything I talk about is not FDA approved, it's not covered by insurance, it's considered experimental and investigational. So this is not in the sense of mainstream medicine. This is alternative treatments when everything else has failed. So this is the first thing I'd like to make sure that everyone understands, that there's no FDA approval of what I do, and I only use my 31 years of experience to talk to you about where we are in 2025 in interventional pain management and spinal treatment of patients with chronic pain. So with that being said, I'd like to make sure that you can reference to the YouTube that was done several years ago that talked about intradiscal ozone therapy and spinal augmentation. So instead of actually talking more about that, I'd like to go right into where we are today in 2025 and how I've advanced from intradiscal ozone therapy to where we are going from now and down in the future. So with that being said, I'd like to put your attention to slide number 1. Slide number 1 talks about advanced interventional pain treatment using ozone therapy and regenerative medicine. Now this is where we talked about intradiscal ozone therapy, but we're now going to add a little bit more to intradiscal ozone therapy and talk about where we are going down in the future. Slide number 2 talks about the objective. So the objective, go back to steroid. Steroid is basically obsolete. We need to understand your options, and in that being said, you need to understand what the epidural space is and the inflammatory environment. Ozone is great, but other agents can potentiate its benefit as well. Epidural has been around, I tried to make a joke about it, as long as the ages of dinosaurs. And that's slide number 3. And there are various types of steroid that have been used throughout the years, which is listed in the slide. Slide number 4 shows the first epidural steroid injection was recorded in 1952. And it's been used over 70 years to treat patients with back pain and radicular pain. The reason that you use steroid because it reduces inflammation. It's inflammatory reduction. Slide number 5 shows basically people get epidural steroid injection, but it's not FDA approved. It has actually been labeled as potential embolic complication with steroid injection, and there was a black box label on steroid use many years ago. So even today, it's not a standard of care as far as FDA approval. It's been used as off-label. Slide number 6, we talked about the epidural space. When you're trying to treat an inflammatory environment, you have to understand what's in it and what you're trying to treat. So we need to understand there are 5 reasons that people have back pain. Number 1 is discogenic pain. The disc is the source of the pain. Number 2, the neuropathic pain. The nerve is being compressed and it creates pain either in the back, down the legs, or localized in the spinal region. Then you have number 3, osseous or bone pain, which because the bone has inflammation and it causes pain locally. There are these joints called the facets, and number 4 give you what they call fascogenic pain, which can give you back pain, and sometimes it can mimic or make you think that you have a radicular pain going down your leg. And number 5 is what most people go to see a chiropractor or massage therapist for. They call it the spinal or myofascial muscle pain that gives you localized back pain. Slide number 7. If you understand the pro-inflammatory cytokines, and it's very complicated, but I would not get into the weeds of all of this, the thing, but basically, there are a lot of things in the spine that causes inflammation, pro-inflammatory, which is substance P, all those things that's mentioned on that slide number 7. Slide number 8, there's also these nerve growth factors that's within the spinal region as well, that basically if you look at the bottom, it says activation of the above leads to pain and inflammation. That's the key point of this slide number 8. Go to slide number 9. Slide number 9 shows the anatomy of the spinal region when you're looking at the disc, which is the gray area with the little nerves around it on the outside. And then you have the nerve, which is the yellow, which is coming out of the canal, the foramen. And then you have the area called the medial branch and the DRG, the dorsal root ganglion. So that slide actually is the anatomy of the lumbar disc. Slide number 10 shows the nucleus pulposus. The nucleus is basically where all the inflammatory agents are located. So normally, the nucleus pulposus is immunologically privileged tissue. That means there's no inflammatory response in the nucleus. So what happens as time goes on, it generates what they call the pro-inflammatory cytokines, which contact these cells called macrophages that creates pain. When you have a normal situation, pain does not occur in a normal disc. Slide number 11, Number 11 shows the aging and degeneration of the disc. Everyone gets degeneration of the disc. The degeneration occurs probably in the 20s and definitely in your 30s, where the tissue injury causes pathological changes, and you have disc herniation, annular fissures, and then you have an interaction between the nucleus pulposus and the macrophages, the cells, and then you have the activation of the pain pathway. Slide number 12 shows a disc herniation. When there's an injury to a disc, it could be a herniation, it could be a protrusion, it could be a bulge. All of those things can cause inflammation and trigger what they call the macrophage inflammation and activation of the pro-inflammatory cytokines and pain. Slide number 13 shows the neuropathic pain. When you have neuropathic pain, you have either a mechanical compression or a non-compressive. So the mechanical pressure on the nerve stimulates the pro-inflammatory cytokines and the neurotransmitters. The non-compressive part of this causes a histological change of the nervous fibers, and this causes a decrease in the nerve conduction velocity, and this triggers pain as well. Slide number 14 shows the importance of cytokines in the mechanism of neuropathic pain is being increasingly recognized as being the target of treating patients with pain, and not necessarily going in there and doing invasive things such as cutting things out, but we try to modulate and change the environment and the spinal canal. Slide number 15, that shows the different part of the spine again, which we talked about, which is the DRG, the dorsal root ganglion. And that's basically the therapeutic target for chronic neuropathic pain. And that's where a procedure called transforaminal epidural treatment using various types of agents is targeting the dorsal root ganglion to try to decrease the hyperexcitability of that area to reduce the pain. Then you have osseous pain or bone pain. There are three different types of changes that occurs in the bone, which are called modic. You may see that in your MRI report that says modic type 1, modic type 2, or modic type 3. The one that usually causes pain and inflammation is modic type 1, which is the acute inflammatory changes that occurs in the bone that triggers acute low back pain. Slide number 17 shows what are modic changes. Well, these are things that you may see on the MRI findings when the radiologist describes what he found on your MRI. So I will not go into the details of that, but basically this tells you the three different types of modic changes that occurs when you see an MRI report. This slide number 18 shows modic type 1 change, which is the one that causes inflammation. You can see the changes with the arrow of the bone no longer being gray, but also a whitish color of the bone. That's inflammation at the end plates that creates this back pain. Most patients, slide number 19, most patients do not have what they call discitis. I've treated several cases of this in the past, and it's also an inflammatory response. Slide number 20, that shows basically an MRI report, and it shows the different types of findings that we have in the cervical and thoracic region of a patient with discitis. Slide number 21 just shows the post-treatment that has improved with the treatment using interventional treatments using ozone and regenerative medicine in patients who had an inflammatory response in the spine. Slide number 22 shows the fasciogenic pain. And a lot of folks have fasciogenic pain, which is the facet joints on the slide that you showed the anatomy of the spine, that shows that the facet joints have all of these characteristics. They're a joint that has mobile characteristic, they can degenerate, and they can cause inflammatory response and pain. Slide number 23, we talked about the myofascial pain, which usually resolves with physical therapy and or massage therapy, and that's usually one that's most likely to go away very quickly within the first 4 to 6 weeks of having any kind of back pain issues. Slide number 24 goes to where we talked about all of the reasons that you have the inflammatory response in the spinal canal. Why are you using ozone? And we talked about ozone, intradiscal ozone, in the previous YouTube video several years ago, when you're actually putting ozone into the disc and also putting ozone outside the disc in the periganglionic region to try to modulate the pain that's being created from the inflammatory response. Slide number 25. It tells you the mechanism of action of ozone in the epidural space. And this is a very powerful statement. When it comes to extruded disc herniation, ozone is the only etiological treatment that can stimulate the immune response to absorb the herniated portion of the nucleus pulposus, thus resolving the disc extrusion. I have two very classical papers and evidence of a cervical disc and a lumbar disc of patients who actually had ozone treatment as well as regenerative medicine treatment that showed a resolution of the disc in the MRI pre and post. And I will refer you to my website to take a look at those pre and post injections of the cervical disc and the lumbar disc, which is available on the website. Slide number 26 talks about the biomechanical response of the vertebral disc and when it degenerates and the oxidative stress that causes chronic inflammation. And that's the target of intradiscal ozone. When you have a mechanical issue in the intervertebral disc that you're trying to resolve using ozone therapy. Slide number 27. Ozone is considered as a regulator of this oxidative stress, and therefore it relieves the inflammation, and that's why we use ozone therapy intradiscally to modulate this inflammatory response. And once again, ozone has been used for probably over 50 years in various countries with a high degree of safety, with virtually no complication, using this therapeutic agent to help relieve the inflammation inside of the disc. Slide number 28 shows, once again, ozone acts as a therapeutic source that would actually resolve the disc and will help repair the intervertebral disc space. So the key word is to help to repair the intervertebral disc space. So we talked about ozone a lot in the previous YouTube video, and this is where I'm going to as far as telling you about the advancement of my practice over the years in when you add different modalities to ozone therapy. And slide number 30 talks about when someone with a hammer, to someone with a hammer, everything looks like a nail. So ozone is a fantastic agent. It's my number one go-to treatment protocol. But there are other things that you can actually add to the ozone that can actually enhance or make the effect of the ozone even better. And this is the new and upcoming treatment where you talked about the role of exosomes. They also talked about using PRP, using cellular regenerative therapy, actually using it to include in the disc injection or even epidurally to stimulate and reduce the inflammation that's occurring from the pathological response from the disc herniation or the impingement of the nerve. So the therapeutic role of exosomes. There are four distinct characteristics of exosomes. Number one, it lacks an inherent risk associated with cell-based therapy, which includes stem cell. It lacks of replication potential and the risk of malignant transformation. Number three, it lacks immunogenic response towards infection or cancer. And number four is targeted action at the site of interest. So you can use this in addition to ozone to actually help to stimulate the environment to reverse the inflammatory response that's been created from the pathology, which includes the herniated disc or the impingement of the nerve root. Various things that you can use, and one of the things that I use in my practice is a product called Mavix. Mavix it's not FDA approved for what I use it for. It's off-label use. Just like I tell patients, steroid is off-label use as well. But it's been shown that you can actually help modulate the environment with certain types of agents to create an environment that's conducive to healing and regeneration. Mavix has these different growth factors, and it has a lot of what you call matrosomes to help to reduce the inflammatory response in the epidural space. Slide number 34 shows the cytokine panel, which you can actually modulate by using certain agents like Mavix to reduce the inflammatory response. And if you look here, there's one that's called interleukin 10 in the serum. In this patient, it's at 20.5. After treatment, you can see the interleukin 10 level reduces to 3.2. So there was a significant drop in that inflammatory response, which was scientifically shown by using blood label and blood analysis to show you can reduce the inflammatory response of the cytokines. Slide number 36. One of the other things that I use in addition to ozone and also the cellular regenerative products is magnesium. And magnesium works by having an anti-inflammatory effect at the cellular level, what they call the NMDA receptor. So that could help with the centralized pain to reduce the hypersensitivity along with potentiation of pain. Slide number 37. The essence of magnesium sulfate, it acts as an endogenous calcium channel antagonist at the neuronal synapse, thought to prevent excessive activation of the NMDA receptor by excitatory amino acids such as glutamate, and to downregulate the pro-inflammatory pathway, once again to reduce the inflammatory response. Slide number 38. We talked about the Williams methodology and what it includes. In this slide, it shows that you can use ozone, a small amount of decadron, magnesium, Mavix, and other products to reduce the inflammatory response in the epidural space. The Williams methodology using the spinal injection is actually, we did a white paper, which I'd like to refer you to on the white paper on my website, that actually says the exobiologic assessment of Mavix in reducing pain and improving function of patients with chronic spinal condition, a retrospective analysis. It's a white paper that showed that there's a tremendous safety margin when you use this protocol to help people with spinal inflammation and spinal pain. Slide number 39, it says the Williams methodology of epidural regeneration with ozone and biologics, and that refers to, once again, that paper that we mentioned earlier. Slide number 40. It talks about the same thing in the thoracic region of the spine. Slide number 41 shows, once again, in the lumbar region, the same process of helping to reduce the inflammation in the epidural space in the same white paper that was produced and mentioned to in the website. Slide number 42 is a picture of a spinal injection and how it spreads to relieve the inflammation in the entire epidural space from the epidural approach using the transfemoral approach to the spinal inflammation. Slide number 43 shows the imaging of the fluoroscopy of the spinal region of the dye into the epidural space. Slide number 44 talks about the caudal approach. So there are different ways that you can approach the spine. You can do a cervical approach, the thoracic approach, the lumbar approach, or the caudal approach, and that's looking at the spinal region from the neck all the way down to the tailbone. Slide number 45 shows not only can you apply this technique to the epidural region, but you can also apply it to joints and tendons. And there is another white paper that's referred to in the website, and the white paper is mentioned as the exobiologic assessment of MAVICS in reducing pain and improving function of patient with chronic joint condition, a retrospective analysis. And that can be found on my web page as well. This slide number 46, basically the studies show that there are preliminary results when you treat with the Williams method, and this is all documented in the white paper study that's available on the website. So once again, I would like to thank you for your attention and trying to get an updated view of where we are as far as not only are we doing intradiscal ozone, but we are adding other agents to the treatment, which includes a cellular product that could be safely done. It's off-label. You can also use your platelets, which is called PRP, and you can use it in combination with that as well. And you can also use different other agents in the periganglionic region, such as magnesium, clonidine, and also you can actually add local anesthetic. The study that I mentioned earlier, we did not add local anesthetic to the treatment protocol, but there is a local anesthetic called ropivacaine, which can actually be added to stem cell treatment, and it actually has a very small effect on the stem cell function. It's one of the safest anesthetic that you can use. It's even safer than procaine, which has been used by a lot of ozone doctors when they do what they call prolotherapy with using procaine. But I actually have researched and found that ropivacaine is actually a better and safer local anesthetic to use with stem cell-based treatment. So thank you once again for your attention to this new and updated video addressing not just using ozone therapy, but using ozone plus additional modalities to even get a better outcome. And if you have any questions, you can contact me at my office, but you can also go to healthgrades.com and put Alden B. Williams, either San Antonio or Bernie, and you can see what many patients have actually documented as a result of the treatments using this technique. Thank you and have a wonderful day.